Everybody is a critic. Don't want to drop a beat, but I'm serious as a heart attack. And last one, I oughta swear that I'm done with puns, but you know me. So before we get going, let's go ahead and open with prayer, and then I'll introduce our speaker. Father God, we thank you so much for this opportunity to learn about this wonderful thing you've given us, our hearts, and how to care not only for that small organ that does so much, but for our whole bodies. We pray you will please open our minds to be receptive, and that those who need to hear will hear, and that you will bless our speaker. In your name, amen. Now, how many of you guys have seen this postcard before? What do you think? Does it look good? Thank you. I wonder who designed it. This is about affirmations, right? And our speaker is Sharon Esperson, and we have some really cool connections with her. We find out each year that everybody that God brings to us comes from a different avenue that we never even thought of. It kind of sneaks up on us. And I believe we have a connection with Carol and Jackie. So just wanted to welcome you up. And if you want to kind of tell us a little bit more about you and your journey to here.
Am I not? Oops. I guess it's working. As she said, I'm Sharon Esperson, and Carol Keatley is my sister, and Janet Beaver is my niece. So I do have a connection here. I think maybe the last time I was at this church was for Janet's wedding. So that's been a while. I drove right past it. But I realized I didn't want to be in Albany, so I turned around and came back. So we're going to get some slides up here soon. Okay, so just to give you a little professional background, I graduated from Walla Walla in 1974 with my bachelor's in nursing. And then my career has been pretty much always hearts and lungs. I ended up in Loma Linda. In 1978, I received my master's. And then I worked at Salem Hospital as a critical care specialist for many years. Ended my career as a nurse practitioner by going back to OHSU and getting my nurse practitioner. And for the last about 20 years, I've been a nurse practitioner at Salem Cardiovascular Associates. If any of you have the privilege or bad luck of needing Salem Cardiovascular Services, the clinic actually closed the end of December. It joined with another practice, so I chose that as a good time to retire. So since the first of the year, I've been officially retired. So heart disease has been something that I've focused on for many, many years. And it's a very interesting topic. It was interesting, you know, when I first started in it, let's see, so it was probably 1975 that I first went to critical care, and I remember very clearly the first time I had a patient arrest. And the joke about the defibrillator, you know, I remember the patient arresting, and I was orienting, you know, new grad type of person, and this experienced nurse ran in there with the defibrillator, and I'm supposed to be helping this patient breathe, and the patient is blue. And I'm thinking, well, this is not going to work. You know, shock pink. You know, so I was a believer from then on. It's just, you know, the heart is just so interesting. So I have really enjoyed my career. So, and then we will probably have time to talk about a case study. And I have 3 sisters. I called one of my other sisters yesterday and said, is it okay if I talk about you at this presentation? Because we have a sister that had a heart attack when she was 52 years old. So that has influenced our family very personally. So we'll share that story. So this is our topic. Let's see if we can Okay, so on your table you have little tidbits of information, and so they glean that information from public knowledge type of things. So hopefully that we've gotten beyond these myths. But it certainly used to be a common thought that heart disease is a man's disease. We know differently now. We used to think, oh, women don't have heart attacks. We used to think that heart attack symptoms are the same for men and women, and we'll spend a little bit of time talking about that today. The fourth one there, I can't get heart attack. Heart disease if I'm a healthy weight, have normal blood pressure, or have healthy cholesterol. I wish that were true. That would be a very big reassurance to a lot of us. And then the last one, I'm premenopausal. No, I'm not. But those of us who are premenopausal are safe from our heart attack. We used to really believe that too. But I'll tell you, if you'd been with me for the 20 years I worked at Salem Cardiovascular, we have seen heart attacks of all shapes and sizes. So those are myths. The truth is that it is the number one killer of women, and more than the next 7 causes of death combined. I'm supposed to be able to read these from there, but that's really not clear, so I don't know if you can help that at all. Yeah, it's not bright. So anyway, it's all right. Where it says here that many women have no obvious symptoms, and that's silent heart attacks, you should realize that's men and women. Silent heart attacks are quite common in men and women. So that, boom, they didn't have any symptoms. Although, if we're able to chat about it after the fashion, you can find out, oh, they did have some suggestive symptoms. They just hadn't dubbed that as being heart symptoms. So, and then heart disease is increasing, especially, notice those ages. That's young. 35 to 54, that's young. Those of us who are on the top know that. Okay, now what you want to see on this trend, so the red is the female, the blue is the men. You can see that it's higher. This is the death rates. Okay, women is higher than men. The nice thing is the curve of that is going down. Okay, I read in the Oregon Public Broadcasting, I listened to OPB, and they had a presentation recently on chronic disease in Oregon, and so I printed out this, that since 2012 in Oregon, heart attacks, hospitalizations have been increasing significantly. Oregon consistently leads most Western states in factors that lead to chronic disease, such as obesity, high blood pressure, and smoking rates. Oregonians are getting fatter. Around 30% of adults in Oregon are obese, and that's up from 28% in 2012. So, and what's even more troubling is that since 2012, that obesity increase has been among children. So we're worried about that, significantly worried about that. So we like the trend of that going down, but we need to keep it up. So they said that 2 years ago you talked about breast cancer. Breast cancer is horrible. I'm glad you started and had the education on that. But you know what a lot of times you don't realize is that the lifetime risk of having cardiovascular disease is 1 in 2 for women. For breast cancer, it's 1 in 8. So that's a big difference. And then that bottom line, only 54% of women recognize that heart disease is their number 1 killer. We don't view it as the enemy that it is, unless, of course, it's come knocking on your door or your sister's door. Then you do view it as that. So, stroke is, when we talk about heart disease, stroke is a kissing cousin The same factors affect the brain vessels as the heart vessels. So by preventing heart disease, we're preventing strokes also. It's all vascular disease. Okay, so we're going to start with, because I always like to start with a little bit of anatomy and physiology, because it's been a while, hasn't it, since you had your anatomy and physiology. Some of you, that might have been in health class. So I brought a heart. You can't see it from there, but we want to reacquaint you with that heart. So just really starting at basic, you think I pledge allegiance. Well, your heart is really more central. So it's right under that sternum. That's why CPR works. I graduated from nursing school in 1974. It did not... Yes. So I graduated in 1974. We did not have CPR in our nursing program because it had not been officially dubbed as being, as important as it is today. But CPR works because the heart is right under the sternum. I left my slide advancer there. Okay. You can see this. So what you really want to get acquainted with are the coronary arteries on the outside of the heart. So the blue and the reds, that's the coronary arteries. Those are really what we're talking about when we talk about cardiovascular disease or coronary artery disease. It's those vessels on the outside of the heart because their job is to bring blood to the heart muscle, not to the body, but just to the heart muscle. So when someone has a heart attack, that means that one of those coronary arteries has been plugged. There's no blood going through that. So a part of the heart muscle is deprived of blood. That's what a heart attack is. What we try to do is to identify heart disease before it gets to that point. Okay? So a lot of times we can see, there are symptoms of it, we can diagnose it, we can treat it, we can prevent that heart attack. But coronary artery disease, so you've heard of people going in and having angiograms and stents. They thread a little catheter into those, usually from the arm now, used to be from the groin. They thread a catheter in there, they use a balloon to inflate it, and then they often will put a stent, which is a kind of a metal bridging in there. Okay? And that can prevent a heart attack. I had a brother-in-law have one of those a few months ago, and his wife thought it was up here that they were putting it. I mean, she just didn't have a concept. So that's why I try to be very specific so people understand. When we talk about coronary artery disease, going in for an angiogram or a stent, we're talking about weaving clear up to the heart and to the outside of the heart and trying to help the blood flow of the heart improve. And then the next slide on the side is showing you the inside of the heart. So coronary arteries are supplying the blood to the heart muscle itself. The inside is where the blood flows that goes clear to the body. Okay? So that's the job of the heart. So we want the coronary arteries to be healthy so the heart can be healthy so it can do the job of the heart, which is to pump blood. So remember, you learned somewhere the right atria, the right ventricle, the left atria, the left ventricle. That's the pathway of the heart. And then it shows you the valves. So you have 4 different valves in the heart. And we're not going to go into that a lot, but just to remind you that that does become significant. Coronary artery disease can lead to other kinds of disease, or other kinds of disease can lead back to coronary artery. So we'll be talking about that. Okay, this is kind of a cross view of those valves, opening and closing valves. Okay? Some of those have what we call 2 leaflets. You can see where they're divided in halves, and some of them have 3 leaflets. That becomes significant when people have valvular heart disease, and they may have to repair or replace those valves. Okay, we lost something here. Oh dear, this is not looking good. Wonder what we lost there. I think what we lost there was a picture of the electrical system of the heart. Okay, so we've been talking plumbing. You know, what I'm going to do is turn my computer on real quickly, so in case that happens again, I can see what we've... Okay, so actually, the slide before this, it was showing the heart. So we showed you the right ventricle, the left ventricle, the pathway. What I wanted to also remind you is that the heart sits right between the lungs. So the blood flow of the heart is the blood all comes into the right side of the heart, then it goes into the lungs. Then it comes back from the lungs and goes into the left side of the heart and then to the body. That becomes a very important concept to remember, that all the blood from the right side goes into the lungs, come back to the heart, and then goes to the body. Why that's important is because if the heart starts having problems, a lot of the symptoms that you notice are lungs. So it's hard to breathe, or you've got a cough, or it just seems like you huff and puff all the time. That's because it backlogs into the lungs. So keep in mind that, one of my favorite patients that I cared for over my career in the clinic was, I first met him when he was 15, and he had heart failure. But they thought he had pneumonia. And he was treated for pneumonia because it was all lung symptoms. And when he was finally diagnosed, it made sense, but he ended up having a heart transplant. It was that bad. But, okay, and then the other, keep losing this. I'm a wanderer, so it's hard when you tell me I have to stay someplace. I'll try that. Okay, so the other slide that it didn't show was a picture of the electrical system of the heart. And we may run into it somewhere else because maybe I rearranged the slides and then made the copy. But the electricity of the heart is separate from the plumbing of the heart. So when we talked about those coronary arteries, and when we talked about the valves, and when we talked about the blood flowing, that's all plumbing. That's all fluid movement. That's completely separate than the electricity of the heart. So the electricity of the heart is a specific pathway of the heart that starts up in the right side of the heart, the upper right side, goes through to the middle of the heart, and then down through the bottom of the heart. It's an electrical pathway. If any of you are electricians or married to electricians, it's got a specific electrical pathway. And so the thing is that sometimes that will get fouled up and we'll have arrhythmias. And sometimes that will get really fouled up and we'll have the arrhythmias that require the defibrillation. But the electrical system may have problems that have nothing to do with the plumbing system. And the other way around. You can have plumbing system and the electricity is fine. Which I also had a picture there of an EKG. You go, you get hooked up, and they run these EKGs, and you think, oh, good, they said it was normal, so I must be fine. An EKG is one moment in time. It doesn't give you any promises about the future. It only tells you what's happening now. Okay? It does not predict. And that's really important for people to realize. So that's why when we want to test more, we're going to put you into controlled situations like a treadmill test or some kind of a stress test. Because then we ask the heart to do more, and maybe you're fine at rest, but when we ask the heart to do more, you get some suspicion. Okay? So EKGs are nice, but they only are a point in time. Okay, so here's really, when we talk about heart disease, this is kind of all the different types. So coronary artery disease, that's like a heart attack, a myocardial infarction, an MI, all those are the same. Angina means just heart pain. Coronary ischemia, that's a common word you'll hear. It means lack of blood flow to the heart. Okay, so if those arteries on the outside of the heart are plugged up, you're going to end up not having enough blood flow, and the blood carries oxygen. So coronary ischemia. Cardiomyopathy. This person who introduced talked about, she said something about she knew you all had big hearts. I hope not. You don't want a big heart. Your heart should be the size of your fist. And it's kind of Valentine's shaped, okay, smaller at the bottom. If you have a big heart, that means you have cardiomyopathy. An enlarged heart is not a good thing. I know what she meant. But so cardiomyopathy is what the fancy name, I guess, for heart failure or congestive heart failure. So coronary artery disease can lead to cardiomyopathy, but sometimes cardiomyopathy will just show up in itself. Pregnancy. Some women will develop cardiomyopathy as a result of their pregnancy. If that's the case, that's one of the only causes of cardiomyopathy that actually is completely reversible. Deliver that baby and you will normally go back to being fine. So stroke, we talked about briefly that a stroke is just a plug in the cerebral arteries in the brain, the same as a plug in those coronary arteries. That's what a stroke is. Okay, valvular heart disease. I showed you the pictures of the valves. Some of you may have, or you may know people who have valvular heart disease. I put a stethoscope up here because I wanted to remind myself, this is such a sacred item, right? So the doctor or the nurse practitioner always listens to you. So, I can listen and say, oh, your heart is great. No, I can't. I can listen and I can hear if your electrical system is regular. I can hear if you have lung problems, and I can hear if there's some leaky valves. That's what a murmur is, a leaky valve. But there's a lot of things that this is not going to tell me. So there's nothing really sacred about this. Just because it sounds good doesn't mean it is good. But as far as valvular disease, a lot of times this is the best tool that I have to tell me, I think we need to do something more like an echocardiogram and find out what's going on. Okay, cardiac arrhythmias, that's the electrical system. So women tend to have problems with palpitations. That might be an electrical problem. It might be a valvular problem. You can get a valve that's kind of a floppy valve. And then the last one is congenital heart disease. So you may have been born with a problem. And sometimes some of those congenital heart disease don't show their ugly face until later. One of the common ones is you're going to have a hole between the right and the left side of the heart. And maybe you can live with that for a long time before it starts to be known. Those are all the types of heart disease. We're going to really focus more on just coronary artery disease because that's the most common. Okay, I also like to, in addition to doing a little bit of anatomy and physiology, I like to give credit to how we know what we know. And that's because there are a lot of researchers out there trying to figure out what we know. Like I said, CPR didn't even get figured out until after I became a nurse. A lot of other things. My very favorite study that I always give credit to is a Framingham heart study. The Framingham heart study started in 1949. There is a little town in Massachusetts, Framingham, Massachusetts. At the time, in 1949, there were about 10,000 population. They enrolled over 5,000 of those adults in this Framingham study. And every 2 years, those adults had lab tests, had reported their health care. All of those 5,000 were without heart disease when they started. And they have continued to study them from then, from 1949 to now. So they are now including not only their children, but their grandchildren. So a lot of what we know about heart disease came from Framingham Heart Study. The fact that smoking causes heart disease, that is common knowledge now. A first grader could tell you some of the common risks of heart disease. In 1949, that would not have been true. Those people smoking did not realize that it caused heart disease. Blood pressure causing heart disease, cholesterol causing heart disease. All of the common factors we can credit the Framingham study for. Now, Framingham was very helpful. It did not have a good representation of women as much as we would have liked to. So that's why some of these other studies came into being. The Nurses' Health Study, it's not a heart study, but it's a health study. It included heart health. But that 1980 to 1994, there were 127,000 nurses. I've talked to nursing groups, and almost always, I'll say, were any of you involved? And, there's some that were. Very large group. We learned a lot of things about women and heart disease. The heart and estrogen replacement study, HERS, that was very specific to just estrogen replacement. Used to be very common knowledge. In fact, I remember, I don't know if you do, Carol, that our mother, I remember her doctor wanting to put her on hormone replacement so that he could protect her from heart disease. That was just common. I also remember our mother didn't like to take medicine, and going on hormones, it kind of made her breasts and she stopped it. But we know that it is not helpful. It is probably negative. It is worse to go on hormones to prevent heart disease. If you need to go on hormones for something else, and it's significant need, that's one thing. But just to do it to protect you, doesn't work that way. Women's Health Initiative, just another study that this was one of the most expensive studies that NIH has ever produced. I mean, I've forgotten the numbers, but thousands and thousands of women were followed for like 6+ years, and it looked at not only hearts, but also cancer and also osteoporosis, which is an issue. And then the last study, Women's Ischemic Syndrome, or WISE study. We're going to talk about that because that really differentiated women and coronary artery disease. And I saw such a direct impact on my practice. And specifically, so I don't know if any of you have ever had an angiogram or a stress test. The common sequence of events is if you have symptoms, we'll get you in, we'll do a stress test. If you flunk a stress test, you'll end up with an angiogram. It used to be, so an angiogram looks in there and sees if those arteries are clear. It used to be that if a woman, they say, oh, your arteries are clear, that must have been a false positive on the stress test. That's not the case anymore because we know men and women are different. So we're going to make this point of talking about that. Okay, symptoms that indicate a woman may be susceptible to the heart attack. Chest pain. We used to say, oh, women don't have chest pain. Oh, yes, they do. But the other thing is that women have so much more than chest pain. So a man is, there aren't too many men around. A man is such a simple being, right? Oh, my chest hurts. He doesn't bother to say, yeah, and I feel a little dizzy, and I'm kind of nauseated, and, they're just not as descriptive as we are. So what happens is women overwhelm the medical personnel sometimes by how many symptoms we have, and we might have said chest pain, but we're saying other things too, and they lose sight of the fact that we said chest pain. So pain in the arm. When I was in my nurse practitioner role, I always tried to say, do you have any chest, arm, neck, or jaw discomfort, upper back? Not just chest, but chest, arm, neck, jaw, upper back, discomfort, tightness, heaviness, achiness. Oh no, I don't really have pain. I just feel like tightness, heaviness, achiness, discomfort. Okay? Your definition of pain and my definition of pain might be different. But we're talking about, it just doesn't feel right. My sister who had the heart attack, it was her neck. Oh, I got such a spasm in my neck. That was her primary symptom. So chest, arm, neck, jaw, upper back. Stomachache, nausea, breathlessness, getting out of breath easily, sweating, fatigue, weakness. Okay. So I guess what I want to say is, anything upper body, you just kind of have to, I have been blessed with good health. But last winter, we live on a hill. And remember, we had some snow last winter. And so we were having an event at our house, and I really wanted the roadway to be clear. So my husband and I were out shoveling the snow, and all of a sudden I just got this nausea and lightheaded and dizzy, and I had been shoveling snow in the cold, and and I went in and laid down, and I had to lay on the floor, put my feet up. I'm saying, oh man, if this was happening to my husband, what would I do? And so I ended up calling 911 because I was worried about myself. By the time, or he did, but by the time they got there, I knew, we're okay here. But the point is, I said to myself, practice what you preach here, Sharon. Okay, so cardiac risk factors. I think most of these are not going to be a surprise. Smoking, high blood pressure, high cholesterol, diabetes. Diabetics have twice the incidence of heart disease as non-diabetics. It's a biggie, folks, especially for women, and we'll talk about that. Obesity, lack of exercise, psychological factors. So that was last year's presentation on it has a direct effect. And in fact, there's actually a disease now that we're not going to talk about, but the broken heart syndrome, and it's real. Those top ones, you can have something, you can play an impact on that. The bottom ones, age, family history, and ethnicity, you don't have, nothing we can do about those. So we can't change those, although you need to be aware that it does increase or decrease your risk factor depending on those. Okay, so what we want to talk about are some gender differences. So with diabetic, there's a higher incidence of diabetes in women than men. And there's a different treatment. So women are less likely to be able to get to goal. With diabetics, we have an A1C goal. It's harder for women to get there than it is for men. Bad news there. And then the different outcomes. Women have 25% more likely to get coronary artery disease from diabetes, 27% higher risk of getting a stroke. So it's more significant if you're a diabetic than it is if your male counterpart is a diabetic. Okay, I'm assuming, because this is in a Seventh-day Adventist church, that probably don't have many smokers here. But men smoke more than women, and that's still true. Women are less likely to be able to stop with some of our adjuncts, such as the nicotine patches. And the risk of smoking, of coronary artery disease from smoking is higher. Young women who smoke and who use birth control pills, that's a big whammy for heart disease and strokes. Big. Okay, gender differences for high blood pressure. There's no difference in risk for cardiovascular disease on men or women. So both are at equal risk. But the important thing is to think back on your pregnancy. If you had preeclampsia, then that increases your risk of having cardiovascular mortality from high blood pressure. Since we're talking about the pregnancy, think back to the pregnancy. If you developed diabetes while you were pregnant, and then you delivered and you got rid of that, your risk for developing diabetes later in life is very increased. If you had a high-weight baby when if you had a high-weight baby, your risk of developing diabetes is much higher. Okay, well, there was a picture here, and we've already talked about those coronary arteries, but this was showing you a side view. If you cut the coronary artery, instead of being nice and open, it's narrowed. And then this, if you can see, this is showing you an angiogram of a coronary artery, and the artery, you see how that's narrowed? That's how specific we're able to see. And they're saying, oh, your symptoms are because of that narrowing there, and that part of the heart is not getting the blood flow that it needs. Does that make sense? So that's where we would go in and open it up with a balloon and put a stent in there. So they will send you home with before and after pictures when you've had a stent. And it will look very significant. Okay, so this is that study that I talked about, the WISE study. And I told you that you might have a stress test, go on for an angiogram, and they used to say, oh, that stress test must have been false. It really didn't show anything heart-wise. But now we know that women have coronary microvascular disease. So where the plaque accumulates is not in those arteries that they can go in with a scope and see. They can't see those. It's in the microvascular. So if you have coronary artery, if you have a stress test and it shows, oh, we've got a problem here, you do have a problem. It's just not in those big arteries that we can go in and put a stent. That's the bad news. But at least we know that you still have that, and there are things that we can do for that for medication and need to do for that for medication. Okay, so this is just saying that the American Heart Association guidelines emphasize that women and men should be treated as aggressively with everything. Well, there was a study called the Crusade Registry where 350 hospitals reported how they treated heart attack patients, and they collected that data. What they found is, and I'm going to read it here, compared with men, women were less likely to have an EKG performed within 10 minutes of a hospital presentation, which is the standard of care. Anytime someone comes in with heart symptoms, they should have an EKG within 10 minutes of presentation, and women were less likely to have that. They were less likely to be cared for by a cardiologist than men. The medicines were less likely to be prescribed. They did not receive the same medicines that we know need to be given quickly and need to be given consistently for people with heart disease. And at discharge, women were less likely to receive the medicines, cholesterol lowering, aspirin, some of the very basic things. So I really want you to understand that sometimes you have to be your advocate, and you have to say, in fact, one of the things that I've often recommended to women is you have to say, how do I know this isn't a heart issue? So that they have to tell you, oh, well, you're not the candidate for it. No. How do I know? Show me proof. And you need to have those appropriate studies, and we'll talk about that a little bit later. So I think we've covered that. Yeah, there's the Crusade study. This is really important. Women are less likely to seek care than men. Very important. Look at that. Women delay 1.8 to 7.2 hours compared to men 1.4 to 3.5. Why do you think that men don't delay more? Because they've got a wife or a woman telling them, you go in. You need to go in and get that checked. Don't you think? And why don't we go in? Because we're not even telling our husband that we're having that, you know. And, you know, we are responsible for so many people, and we prioritize ourselves pretty low at times. Okay, so here's the essentials. What do we do to protect ourselves? Know your numbers and goals. Okay, so know what you should be at. So know what your blood pressure should be. If you have diabetes, your blood pressure should be under 130 over 80. If you don't, 140 over 90 is a good range to say, I'm all right with that. And we even get a little more lenient if we're over 65. That's for blood pressure. Cholesterol. Know your cholesterol. Has it been checked? If it hasn't, you know, and you're for sure over 50, you should know. Or if you have a strong family history, you should know. Because there are conditions where the cholesterol is just plain high. And that's a condition in and of itself. So it's an inherited condition. So what should your cholesterol be? Under 200 for a total cholesterol. For your HDL, which is the good cholesterol, it should be over 50 for women. For your bad cholesterol, that's the LDL, it should be, if you don't have diabetes or heart disease, it should be under 130. We like it under 100. If you have diabetes or if you have heart disease, we like to push it even to 70. So it depends on where you are, what disease you have. But if you're diabetic, you should expect that cholesterol, the LDL, to be under 100 and close to 70 if you can get it. Now that will almost always take medication, will require medication. My father had heart disease. He had open heart surgery and a heart attack. And I have inherited my father's high cholesterol. So even though I don't have heart disease, I take cholesterol medication because I have high cholesterol and I don't want to have a heart attack. Okay, hemoglobin A1C. If you're a diabetic, you need to know what your hemoglobin A1C goal is. And every time that gets checked, you need to lay your eyes on it and know, am I getting closer to it? Am I going the right direction? Weight. You need to know what your goal weight is. Some of us aren't going to be able to reach our goal weight, but we need to know that we're getting closer to it, or at least that we're not moving further away from it. So weight is important. 5% weight reduction makes huge differences in our risk. So any decrease is significant. Okay, evaluate any cardiac symptoms. So we showed you a big list of symptoms. So any upper body that you don't know why it is. Okay, if you ate whole pizza by yourself and now, oh, gee, my stomach is really, you can figure that one out, okay? Or if you were hauling logs and now your upper back, oh, man. There's some relationship to things that we do. But if you don't know why you're feeling the way you do, then we need to explore that. My sister, who had the heart attack, moved into a new house that had 2 stories. She was carrying boxes up the steps, and she would get chest discomfort. And that was the first symptom that she had. But it wasn't months later that she ended up having the heart attack. So if you have something that you're worried about that may be heart-related, you need to go to your provider and you need to tell them. And you need to say, I'm worried that this might be my heart. Because that puts a burden on them to prove that it is or isn't. Okay? You don't want to have it poo-pooed and just, oh, no, I don't think so. Well, why not? Why do you not think so? So the way that they need to tell you that is that you would need to have a stress test. They'd need to put you on a treadmill and watch your EKG. Or if you're not able to be on a treadmill, they have other pharmacological tests that they can put you on. Or if you're having abdominal and they say, I don't think so, then they need to give you a medicine that corrects that abdominal symptom. Fine. If you think it's an ulcer and you give me treatment for my ulcer and that takes it away, okay, I believe you. But not just I think. We need to have proof. So evaluating cardiac symptoms is really important. I believe strongly that your terminology makes a huge difference. So when you go to your primary care provider, use that terminology of, I'm worried that I might be having some cardiac issues. So then the appropriate stress testing. Okay, the last one there, keep active so you have an early warning system. I used to say this all the time to my patients because, if you're sitting watching TV, that narrowing in your heart may be very narrow, and you're not going to have any symptoms because you don't ask the heart to do anything more than it's able to. It's when you get up and do things that we're asking the heart to do more and that the heart is required of more that those symptoms are going to develop. So one of the best things you can do for yourself is move more. And a really good thing is to have like a walking path or, some form of exercise that you're doing the same amount each time or at least several times a week so that you get your heart going a little faster than usual. You know that you're working out, that you're working. Don't even have to say working out, that I'm working. I'm doing more than usual. And then you can compare apples to apples. Gee, I did this last week, and I could make it clear around the block. Today, I have to stop and rest 2 times. My husband has a stent, and he's not, you wouldn't expect it, but he was on a treadmill, and he just got really diaphoretic and, felt like, oh, I'm going to pass out. So he was at the courthouse. I wasn't with him. And so he got off the treadmill and went to a stationary bicycle and said, oh, then he was all right. He comes home and tells me this story. I said, oh, I don't think so. He also then admitted that when we have a walk that we do, and it's pretty steep apart, and we had a big German Shepherd dog, and he was gaining weight, and the vet says, you need to exercise him more. So that's when we went, instead of walking flat, we walked on this hill. Well, every time we got to this certain place on the hill, he'd get this upper back pain. He hadn't told me about that either. But when he got that I said, I think you need to go visit, And so I got him into our clinic, and he had a stress test, and he flunked it. The interesting thing is that he did the stress test, so they put him on a treadmill and, watch him. When he got it done from that, he says, I think I did pretty good. I said, no, you didn't. You flunked. Because he didn't know, because he wasn't watching the EKG. But the EKG was very clear that when he was doing this, that wasn't looking good. And so they went in and put a stent in, and that's been 2001, a long time. Had no other problems. It was within a week he was back walking that hill and no symptoms. So we walk that hill a lot because that's an early warning system. And, if he's going to have problems, we're going to know it because that's a steep incline. We also do a lot of other things, so we keep very active. The other thing that you need to know is that women, a lot of times, our emotions are actually more sapping than physical. So you may have those symptoms when you're worried the most, or when your feelings have been hurt the most, or more, when you're emotional. Okay, so psychological stress may trigger those. I already talked about that. Oh, this is a nice, it's kind of a busy slide, but it just reminds me to tell you, in that nurses study where they looked at 127,000 women, what they found out is group 2 there, 1 hour of walking per week, they had decreased heart attacks or heart disease than those who didn't. 1 hour of walking a week, how much is that? That's about 10 minutes a day, right? So I like to use that information to encourage people that anything you do activity-wise is going to be beneficial. Okay? I mean, the more the better, but anything you do is going to be beneficial. I'm going to skip that. I think that might be, oh, I thought this was appropriate. I'm going to see if there's, nope, I actually had a slide in there. I want to take the time to talk about my sister, and then I'm going to open it up for questions. Okay? Because my sister, I learned so much from her presentation. So I told you that it was November, and she moved into a new house, and she had the chest discomfort. She didn't tell me about it, but she did go to her doctor, and she told her doctor. She said, and he said, oh, we need to do a stress test. So she went in and walked on a treadmill and had a stress test and didn't hear anything more. So she figured, oh, must be okay. What happened on that stress test is, in order to be a diagnostic stress test, in order to learn something about your heart from a stress test, you have to reach your heart rate goal, and that tends to be 85% of your target. If you're really interested in that, you take 220, subtract your age, and take 85% of that. And that is a target for a good stress test. She didn't reach that. She was not able to stay on the treadmill long enough to get her heart rate up high enough. But no one told her that. So what didn't happen is that doctor didn't say, you know, we didn't learn much from that treadmill. We need you to come back in and do a different kind of treadmill, a different kind of stress test. That's what needed to happen in November. It didn't happen. So by not hearing anything, she assumed, no news is good news, right? Not in healthcare always. Somebody dropped the ball. This was in California, is where she lived. So we can't blame it on anybody we know, but they dropped the ball. It was April, May, I think around April of the next year. She started feeling quite winded, but she is not my most athletic sister. So, we're used to that, when we're with her, we walk a little slower, and she just wasn't. And she was up in Oregon a lot because my dad was very sick, and we just walked a little slower when she was there, and she needed to stop and catch her breath and that. But, that's just the way it was. About a month or two later, she called me and said, I went in for an EKG because she had changed insurance. And the insurance that she went to, her new insurance, she still had old insurance, but she had a new job and they provided new insurance. So she was going to have double insurance. And they had a questionnaire. And if you're short of breath, you automatically get an EKG. It's required. So she had that. And the person who did the EKG said, oh, that's abnormal. The nurse said, that's abnormal. And she said, well, what do you mean by that? And the nurse said, well, it looks like you may have had a heart attack. So when the doctor comes in, my sister says, the nurse told me that it looked like I may have had a heart attack. And here's the best part. That doctor said, oh, you know how nurses are. So he referred her. He said, but we'll get you, if you want to have it worked up more, you can go to this urgent care, and then they will refer you to a cardiologist. It was a strange system. But anyway, so she went to a second place and had an EKG, Sure enough, showed the same thing. Abnormal EKG may have shown an old heart attack. Okay? So there was a scar on her EKG. Now remember, if she were having that heart attack in the future, that EKG wouldn't have shown anything. But we're talking about she had already had it, and the EKG does show a scar. So they said, we need to get you to a cardiologist. So they made a referral to a cardiologist, and they said, you will hear from the cardiologist's office within 2 weeks. Hear from their office, So she called me, and I work in a cardiologist's office. I said, oh, no, you need to. And so she was on a plane the next day and had a stress test scheduled in our office. I've made some mistakes in my life, and one of the mistakes I made with my sister is I did her stress test. I was the person in the room with it. It was the scariest thing in my whole life. It was a bad stress test. So it was a stress test that shows, it was nuclear. So it shows the heart muscle, and you have one at rest, and you have one after the treadmill. She had already had her at rest one, and our technician came up to me and said, Sharon, your sister has a hole in her heart. Now, he didn't mean a hole as in a hole. She meant that there was a big area of the heart that was not getting blood flow. So she'd already had a heart attack, and I'm putting her on a stress test. It was scary. So she lived through that. But we found out that, she'd had a big heart attack, and not only was there a part of the heart that doesn't get blood at all. That's the permanent heart attack. Okay, that's what a heart attack is, a part of the heart that doesn't get blood. But there was an area around it that wasn't getting as much blood as it needed. So she was at risk of having an even larger heart attack. That's my sister. And she was staying at my house, and we have a 2-story house. And walking up the steps, I realized she's stopping on my steps because she's out of breath and having discomfort. Walking up one set of stairs. It was pretty scary. So Dr. I Trust brought her in to our hospital, did an angiogram, put that catheter in, and couldn't get it through. Okay, so the idea is to get through, open it up. Couldn't. It was already plugged completely. Okay, so she ended up needing bypass surgery to supply blood to that part of the heart that was completely plugged. I tell that story because, I didn't tell you either, 52 years old, premenopausal. Yes, we have family history, but our dad was 65 when he had his heart attack. They're not a strong family history. Now we have a strong family history. To have a sister that had a heart attack at 52 is a strong family history of heart disease for another woman. Okay? So why I tell that story is because, it's so important that you know what an appropriate workup is for a heart disease. So in her case, she did exactly right. She went to her doctor. She says, I'm having chest discomfort. What she did wrong is she didn't tell her sister. If she told me, then we would have followed through. But, she didn't know. And so I want you to know that, if you have heart disease, you need to have the appropriate evaluation. Or if someone you love has heart disease, they need to have the appropriate evaluation. And that almost always means to have a stress test, because then we provoke it. We ask the heart to do more, and then we watch the heart. We watch the electricity of the heart. If we're doing the nuclear, we watch the heart muscle, and we see, is it able to get what it needs to get? So she is doing well now, this many years later, but she has a permanent heart dysfunction. So that if you looked at a nuclear imaging of her heart, she's got an area that does not get blood flow, and that's what a heart attack is. So when I showed you the size of a heart, when someone has had a heart attack, usually we're talking about the size of a dime or a quarter compared to the whole heart. So what I used to tell my patients is, that's significant, but sometimes it's a wake-up call. And if we get the rest of the heart in primo condition, we've conditioned the heart, so it actually is better than it used to be, even though it doesn't have that dime or quarter size functioning. All right, I'm going to stop there and see if we have any questions. Uh-huh.
Hello?
Hi.
Hi.
When you first started, you said something about a relationship between a stroke and a heart attack. I have a sister who had a stroke. She's 9 years younger than me. She was in her mid-50s. Does that mean she had a heart attack? Or does
No.
that...
What it means is the same factors that make you at risk for a heart attack, so the high blood pressure, high cholesterol, all those factors increase your risk of a stroke also. So she's at risk of having a heart attack, and because she's your sister, that makes your family history very significant.
My dad had bypass surgery. My mom, my grandma, everybody's had heart attacks. So I know that, that is the case, but it was shocking. My brother, who passed away, also had heart disease.
So did
Stroke.
Okay.
Pardon? He stroked out.
He knew he had had a stroke before, or was it just?
Yeah.
Yeah.
So
So those are both, big risk factors. So stroke and heart attacks, same risk factors. If you've had a heart attack, you're at risk for a stroke. If you've had a stroke, you're at risk for a heart attack. So
okay,
very
thank you.
related.
That you said something about the size of your baby when they're born?
Yes.
What is considered a large?
I think we're talking over 11 pounds, something like
Okay.
that. 10 or 11, I can't remember which, but large babies. But they're, ouch.
I have a question about estrogen and its effects on the heart. It seems like years ago when I was growing up that they said estrogen had a protective effect on the heart for women. But then it seems like after they go through menopause, nowadays when you talk about estrogen replacement, they say, oh, you can't be on it because if you're on estrogen replacement, that increases your risk for a heart attack. So I don't understand how those two fit together.
Yeah, and we definitely changed our tune there. I mean, we used to think, so I think it was because premenopausal women just didn't have heart attacks, so the incidence was very, very small. What's the difference between a premenopausal woman and a postmenopausal woman? Oh, estrogen. So that's how that message got across. But estrogen replacement does not do the same protection as your natural body cycles. Okay? So we just know clearly that the estrogen replacement, hormone replacement, does not protect us. There's some evidence that it may negatively impact us, but it's not as strong as we first thought about it being a negative either. So if you have symptoms that require you to have estrogen, then what we say is, okay, if you need to have estrogen, let's be sure your other risk factors are managed very well. So let's be sure your cholesterol is really at target. Let's be sure your blood pressure is really at target. So all of those things protect you, and then the estrogen is probably going to be insignificant. If you need it, you need it. But it will not help you alleviate heart disease.
I'm interested to know about, you have talking about 85% of something and the minus of age of that individual, then result the information if you are prone to stroke. What is that? Yeah?
Oh, okay.
Yeah, we're
No,
interested.
no. What I was talking about that 220 minus your age and then the 85%, that's
Yeah.
what, okay.
120?
220 minus your age. So 85%, and actually it's 80%, is the target. So we need your heart rate to be at least that high for it to be a good stress test when you're on the treadmill, when we're watching your EKG. Okay? That has some significance for you to know, because if you're exercising and you're watching your heart rates, you should not be exceeding 220 minus your age times 85 to 90%. That should be the highest that you push your heart rate to. Okay, so some people, go to the courthouse and they do these machines and it shows your heart rate. Well, what significance is that? That's what the significance is. There is a level at which you shouldn't exceed that. That's because the heart can only supply oxygen to that level. If you get higher than that, you're going to what we call anaerobic. You're going into exercise where you don't have enough blood supply for that. So you're not having oxygen for all that. And it also gives us some indication that maybe you've got arrhythmia problems. If you just start walking and your heart rate jumps up to 180, that's not normal electricity, and that becomes an issue.
It's a contribution. If our brain doesn't have supply of blood because of the clot, then that part of the brain doesn't have any nutrients, and the blood there will not be cleansed.
No,
Right?
No, it's not cleansing of the blood that we're talking about. We're talking about delivering oxygen to the brain.
And nutrients, right?
Nutrients, yes, but mostly oxygen. That's what a stroke is a lack of oxygen, because the blood flow is reduced to the level at which you're not getting enough blood flow to supply oxygen. Same with the heart muscle, oxygen. When you plug the heart and you don't get blood supply, you don't get oxygen to the heart, and that's what kills that heart muscle. That's what kills the brain tissue, lack of oxygen.
Thank you.
My question is about CoQ10. I understand, I might be wrong, I don't know. I understand that the body produces CoQ10, and if you're on a statin drug, it counteracts that, and your body doesn't make it anymore, and even if you take a supplement, it doesn't work. Is that...
I can't tell you exactly. I can tell you that I know that in Europe, it was pretty common to have CoQ10 as a replacement. In the United States, we have not there's been no evidence of that. So we can't say by a study that is. It is not a common thing that every time you're on statin, you're on a CoQ10. It is not a standard of care, is the only thing I can say to you there.
Yeah, it would be that if you're on a statin drug, it wouldn't do any good to take CoQ10 because it stops it. I've had quadruple bypass for 11, 12, almost 12 years now.
Uh-huh.
And when I'm on the statin drug, I'm sick.
All of them? You've tried lots of different ones?
Lots of different kinds. I just don't feel good. And so I told the doctor, if you don't take me off it, I'll take myself off. And he did. He backed me off of it. And I started taking CoQ10, and I feel really good now.
And what are your numbers? Cholesterol numbers?
Haven't had them in about a year, but they were pretty normal.
So that's the thing. Is there are ways to control? I mean, some people can control their cholesterol without statins. Other people cannot. Our bodies make, the majority of the cholesterol is what our body makes. not what we eat, but what our body makes. Just for myself as an example, you know, I'm a pretty healthy eating person, but I still have high cholesterol. And so, but I tolerate the statins fine. So there are people who, you know, I know the statins are hard to take for a minority of people. It's a minority, not the majority. Most people can take them pretty easily.
This is just silliness.
No.
My mind wondering this. When you have a heart attack, that dime-sized portion or whatever dies, right?
Right. Yes.
It's dead.
Yes.
If part of my finger died, I'd get gangrene. What keeps your heart still functioning?
Well, but if you fall and, you know, you scrape your knee really bad, you get a scar, and it ends up scarring.
Okay, so that
Yeah.
dead part just turns into a scar.
Scar, yeah.
Okay, that
Yeah.
makes me feel a little better.
Yeah, yeah.
How much needed of the heart that you are going to have a transplant?
I ask that again.
How much need for the heart disease
Oh,
for
okay.
you to have a transplant?
Okay. So remember when we showed the list of illnesses and we talked about cardiomyopathy? Let's talk just a little bit about that, where the heart muscle itself is the problem. So it may not even be related to a heart attack. Like my 15-year-old patient, you know, he hadn't had a heart attack. He had a virus that attacked the heart. And what happened is the heart muscle as a whole, it remodeled, it got big and floppy. So usually I'll emphasize that the size of the heart is important because it's an efficient squeeze. You can get a squeeze of the heart and the blood flow is pushed out. Squeeze, it pushes out. When you get a big and floppy heart, it flops. It doesn't squeeze. So usually for a heart, normally 55 to 60% of the blood that's inside the heart is pumped out with each beat. Okay, 55% to 60%, not 100%, but that much. In his case, it was probably 10%. So we're talking a very extreme situation where you don't have much pump with each. And a heart transplant, we know that the risk of death has to be higher. 5-year risk of death has to be much higher than the benefit of a heart transplant. So there isn't necessarily a certain number, although it's getting down there in the 10% range is when. And that's with everything poured into them that we can, all the things that we can do to help them.
You mentioned statin drugs. Can you explain that?
Statin?
Yeah, what are
Okay, cholesterol-lowering drugs. That's like Lipitor, and atorvastatin is the other name for that, or a Crestor. So they're cholesterol-lowering drugs. That's the most common cholesterol-lowering drugs. Lovastatin, just a handful of them. Simvastatin, any of the statins. That's why we call them statin drugs. Yep. So they're all in the same category. Some are stronger than others. Some people have, like she said, she just didn't feel good on them. Some people, a very minority of people, are not able to take them, and that makes it a challenge because they're very good drugs at lowering our cholesterol. One of the most dangerous parts of that is some people can get liver disease from them, but it's very, very, very low percentage. We did it.
All right, ladies, can we all heartily agree that this was very eye-opening? Can we go ahead and give an applause to our speaker? Okay, so you know how she was talking about the stress test and that exercise is really important. So get out your tickets because I only have 10 frames to give away. So this will be kind of like a pre-race preparing you for that. It's elbows out, first come, first serve. Actually, why don't you guys at your table hold up the frames so people know what they're looking for. There's some tables that have empty frames. Now, when you take these home, you could leave these heart-healthy facts in there if that's the motivation, but if you want to put pictures of your family or your dog, or you're welcome to do that as well. So, drum roll, please. Good job. And, okay, now, I'm going to tell you that everyone starts with 813, so I'm not going to keep reading that off. So far, you all are winners.
Okay.
The last three numbers, 921. Who's our winner? Woohoo! Oh, let's be good sports.
You're supposed to choose hers.
Okay.
You have to shake it.
Oh. I'm going to read the next one. So, girl, if you miss out, you miss out. I'd start going around looking those. Okay, next one. 920. Woohoo! Okay. Here's our next one. 905. Woohoo! Back there. Okay, our next one. 907. Did you want to, or were you willing to share? Aw, thank you. Oh, that is great. I love that. She's going to go ahead and give it to someone. Nice. See, I told you us women have good hearts that are perfectly normal sized. Okay, our next one is 889. Anybody have 889? I'll try one more time. 889. Okay, so if no one has it, we will assume it's Stacy's. Woohoo! Nice. Okay, next one is 893. All right, woohoo! Okay. This one is 901. All right, back there. Okay. 914. All right. Okay, so if you look around, we have two more left. Is that yours? I put it down. I'm just saying. People are looking at it. Hey, if you have one, put it down, because otherwise people will be drooling over it. So let me see here. How many? Two left. Okay. 906. Aww.
Oh, it's a good heart.
Okay, and 890 is our last one. Woohoo! All right.
Thank you.
Great. There are a couple of people to recognize about that brought this together. Debbie Cook, there in the back, is one of our ministry leaders. And Diane Rush is also one of our ministry helpers. And and yourself, Elizabeth. And we are very grateful for all the people who helped also put our food together. And now I am told this is a light lunch. Please feel free to go ahead and grab something, come back in here, eat, visit. Debbie says there are leftovers. I'm going to just make one caveat. If you are around long enough for leftovers, could you help us clean up? I'm just saying, it'll really be a good exercise, a little weightlifting, a little cardio. We just need basically the tabletops cleared off and folded up and put to the back and chairs pulled back. So if you're able to do that, great. Otherwise, feel free to go ahead and take some leftovers and go enjoy the sunshine. Let's go ahead and bless our food. Father God, we thank you for this opportunity that we've had today. We thank you for our speaker who has shared not only from her years of experience, but from her own personal experience. You could say she really shared from the heart. And Lord, we pray that we will go away more knowledgeable, not only about how to care for ourselves, but how to help educate others. Bless our food and our fellowship. In your name, amen. Please go ahead and go get in line.